Hello, this is Ted Burns. We are now going to do episode 5 for our RADVOCACY podcast hosted by RADPAC. And we are excited to have with us today Dr. Greg Nicola. And I just want to preface this is going to be an interesting podcast for me because usually we're dealing with political dynamics, we're dealing with advocacy dynamics, and this is a very socioeconomic based podcast that we're going to do today. And I think it'll be very obvious why we're doing this when we're doing this as we get into the episode. So I'm going to really rely pretty heavily on Dr. Nicola. I hope you don't mind.
No, I certainly don't mind, Ted. Thanks for having me.
Great. Well, I always ask this question when we first start out because I'm always interested, at least. And I feel like our audience is also interested because while we know of each other, or sometimes we know each other even more than that in working together on all of our issues, I don't always really feel like I have a good understanding what a member's background is. Where do they go for med school? Where do they do the residency and fellowship? And where are they practicing now? I know where most of the folks on our podcasts are practicing, but just it's really kind of an interesting journey to see where people started and to see how they got to where they are now. So if you don't mind sharing that with us, I think that would be interesting.
Yeah, sure, Ted. My journey was probably somewhat unique in that I was born and raised in the Midwest, went to med school in the Midwest at Case Western in Cleveland, which turns out is my hometown too. And then I did bookend. I went out to California for a year and did a medical internship. I had some family out there I wanted to hang out with for a year and did a medical internship. Then I came to the East Coast, to New York City, where I spent my residency and then subsequently my fellowship at New York Presbyterian Cornell campus, and lived on the Upper East Side of Manhattan, and subsequently laid down roots in New York City. And to this day, I still maintain a residence in Manhattan, although I work in New Jersey and I do a reverse commute every day. So been in the Northeast now for over 20 years.
Is there really a reverse commute, or is it pretty much just bad both ways?
It's actually a complete reverse commute. I'm really lucky. It's okay. About 15 minutes to work in the morning. There's pretty much zero traffic. Sometimes it's a little sticky getting home, but never more than 30 minutes. So it's pretty easy.
And
New York City.
I'm probably going to take a lot of heat because people are going to see a trend, and it's not an intentional trend. But I had Dr. Bello as our first guest. We just got done Dr. Bonnie Litvak as our most recent guest, and now you. So we're on a pretty strong New York run here. And so sooner or later, we'll have to broaden ourselves geographically. But, we wanted to bring you on because of what's happening, like I had mentioned, in the socioeconomic space in radiology. And so as we kind of get introduced into that conversation, as most people know, I'm sure, who are listening, you're chair of the ACR's Committee on Economics. So if you can give us a brief description of the type of work that committee does on behalf of the membership, and then your path in becoming chair of that committee, I think would be interesting too.
No problem, Ted. So the Economics Commission's tasked with really doing the heavy lifting for regulation. Whenever, for example, in your field, Ted, you do a lot of advocacy, you're dealing with the politics. Well, when the politics trickle down to the regulators, they have to write rules and regulations around the laws. And those rules and regulations are sometimes open to input by specialists, namely, let's say radiology, when a rule and regulation impacts radiology. Well, we serve as the liaison for our members to, for example, Medicare, and helping them understand what our sticking points are, where we can best serve our patients, and make sure that they craft, or at least hopefully they'll craft language that pays attention to what our needs are as a provider community, so that we can provide the best care to patients. Now, of course, politics enters that. Of course, they have other objectives that often conflict with our objectives. But we're the voice. Without us, they wouldn't even know what a radiologist does, and we're there to tell them. And we do a lot more than just that. We interact with bodies that have significant impact on the Medicare Physician Fee Schedule. For example, the American Medical Association runs the coding process, the CPT coding process. We have members of the commission that go to the CPT editorial panel, helping craft language around value that we provide our patients. We also deal with evaluation process that the AMA runs through a body called the RUC. And we also have our hands outside of the Medicare payment structure inside of commercial payers. Commercial payers also write regulations. They also have impact on how radiologists practice in the commercial payer world. And so we often interact with them, helping them understand what a radiologist does on a day-to-day basis. So that's kind of what the commission does in a nutshell. I'm happy to answer the second part of that question was, how did I get here? The truth is, I got here because I found ways to educate myself about this process in my practice that actually helped my private practice. I started learning how valuable it is to know Medicare regulation or commercial payer regulation just from billing compliance or understanding new technologies or how to implement change in your practice. It was vital to know that. And so I started learning it as part of the operations in my practice. And then just by chance, I had a mentor of mine, Bob Barr, who now is a past president of the American Society of Neuroradiology, asked me to represent the American Society of Neuroradiology at the RUC, one of the AMA bodies we just spoke about. And I became a RUC advisor for a number of years and found that that passion I developed to help my practice actually could help radiologists nationally. And I became intimately involved with ASNR and economics, and then subsequently also developed a skill set in my practice for value-based care. Part of the government regulations requires us to submit performance measures in a quality program, and that became the foundation for what nowadays we know as a merit-based incentive payment system. Well, I was already doing that for my practice, and it was a natural fit for me to start chairing the committee that had to deal with that on a national level, the macro committee in economics, and kind of just progressed from fee-for-service to value-based care, and then developed a reputation of being able to know economic issues broadly, and subsequently was appointed as the chair of the Economics Commission.
And I'm assuming it's safe to bet that not many others in your practice was fighting over doing what you started to get into?
No, I think for the most part, people stayed away from it like it had a disease.
Right.
For the most part.
Right.
Yeah, it's pretty mundane stuff. You have to have the patience to read 3,000 pages of regulation that comes out several times a year, and then carve yourself through nuanced language. And I found it actually quite fun. I'm probably a little odd that way, but it became honestly a hobby that I enjoyed quite a bit. And then it became something practically that helped my business and then helped advocacy. So honestly, it's a passion that found me.
That's cool. So obviously in that capacity, you're seeing a lot of different trends. You're seeing trends within radiology. You're seeing trends just in the house of medicine in general, as all these parts are kind of very fluid and constantly changing. If you think about radiology in the next year or so, or couple years, what are some of the challenges?
Yeah, thanks for that question, Ted. I will disclose my bias as the economics chair. So these are going to be heavily skewed towards the economics of radiology. There are all sorts of very imperative things in radiology right now, but I'm going to stick with my knowledge center. First and foremost is the economics issues. Reimbursement continues to decline for the profession, yet the volumes continue to go up. Our value continues to go up in the healthcare system as more and more clinicians are stressed in seeing patients, whether it's an emergency room setting or primary care office. They tend to use imaging as a crutch to help them through those busy times. And we're going to see further explosion in that. And yet our reimbursement goes down. So for me, that is always front and center. And it's natural that it's front and center given that I'm an economics chair. Fitting with that is we're now starting to see, and this has been happening now for at least a year, but significant workforce challenges. And when I mean workforce challenges, it's not only hard trying to find radiologists to do the job, but it's hard finding nursing to staff our imaging centers. It's hard to find technologists to staff our imaging centers. I think that virtual jobs and the overall culture of where the United States is going has made being on the ground and doing face-to-face work harder and harder. And people have more options in their career, and they're starting to take them. And medicine in general is facing this crunch, and we are really going to have to focus a lot of energy on how to fill those workforce gaps. And then kind of tying into those first two is scope of practice challenges. This is an extremely important topic for us. We're seeing regulatory scope creep in which nurse practitioners, physician assistants are gaining more leverage and more autonomy in the healthcare system. And honestly, in many ways, it's to address the first two issues I meant: declining reimbursement, where radiology groups are leaning towards lower, cheaper staff to try to fill the gaps in instead of more expensive staff. And then, frankly, challenges of being on the ground at all the time in all your different centers, kind of PA and nurse practitioner staffs fill those gaps. And we're seeing them kind of move into our profession. And then there's been a scope creep on the regulatory front as well, allowing them to do this. So those are the three challenges I think are the most imperative as an economics person over the next few years.
And it is interesting with number two being workforce, number two being the number two issue you listed, and then number three being scope. And I know on the Hill, there's kind of like one's used for the other, or one's used as a reason for the other. And that's kind of where the politics and the advocacy and what you all do kind of all blends in together, right?
Yes.
It is interesting. I was also at the Florida Radiological Society meeting just recently, and one of the presenters was going through some slides that was pretty sobering, honestly, about scope of practice and just kind of how there's a real tightening, and it's an interesting trend and one that I know that we're working on at the state level as well. So these issues are out there. They're obviously huge concerns. What do you see the college is doing to kind of assist or address these issues? I know, whether it's your fingerprints with the economics part of it or just the college as a whole. Obviously, you've got a lot of a network within the college leadership. So what would you say that we are doing or have been doing to try to figure out ways to address these concerns?
Yeah, thanks again, Ted. So this is an important point because it's very hard for us to rave about what we're doing in the national forum because we're working with other specialties that sometimes, with the budget neutral system where winners take from the losers, you're kind of cheering against somebody who is your colleague. But I can tell you, in my experience of over a decade of going to the RUC, which is where we value CPT codes, the amount of success we had there has been very impressive. And it's hard for members to grasp the amount of success when the reimbursement to radiologists keep going down. But the reimbursement's going down for a completely separate issue. It's not going down because the value, the RVU values tied to the services we provide our patients are going down. In fact, we've done a marvelous job maintaining them and even sometimes getting them increased. And that's a team effort by many people in the college. And that's hard to tell the members on how bad it could be if those values weren't maintained. But we've had tremendous success in protecting the value of head CT, protecting the value of knee MRI over and over and over again from these onslaught of challenges and reimbursement attacks that we get from the payers. So we do that virtually every day, but 3 times a year is the meeting that we get challenged on these code sets. Now, recently, we've seen reduction in reimbursements, not because any of our RVUs are decreasing. It's because the structure of Medicare Physician Fee Schedule is there's a fixed pot of money, and if someone gets more, everyone else must get less. And what we've seen a lot of lately is there's a number of very high volume services provided to Medicare beneficiaries, namely the outpatient office visits, now the inpatient office visits, ER visits, that have been upward valued. And that means that there is less money from radiology, even though our RVU, the relative value units, have stayed the same. But radiology is fighting that battle every day. We also do it with the commercial payers. Commercial payers are constantly rewriting rules, trying to redistribute money to other specialties. And we have to step in and talk about what radiologists do on a daily basis. And we are the face to those payers for our broader community of the ACR.
I always feel like we're on the defensive, but that's sometimes also difficult to operationalize to the membership in a way that's really kind of appealing or sexy to them. It's hard to really help them understand just the real value and win that can be, right?
Yeah, that's a great point. I also just want to add that one of the reasons we're often on defensive is that the offensive rules are written and they just either don't apply or we can't possibly fit into them in any way. An example I'll give to try to make this more clear is we've had this trend of moving towards accountable care, and Medicare defines accountable care is if you have patients attributed to you, and the way you get patients attributed to you is you provide an office visit. Now, those are rules we can't possibly follow. We don't have office visits. Therefore, we can't have patients attributed to this. Therefore, by Medicare's definition, it's not true, but by Medicare's definition, we can't truly be accountable for the care. And therefore, we're not eligible for what we call shared savings for people who become accountable in an effective way for their care. And those are rules written against us. They're literally not, they can't apply to us. So it's something we bring up to Medicare all the time and to try to change the offensive playing field. Otherwise, it's very difficult for us to even challenge them in that way.
Yeah, that's I'm sure that's got to be frustrating for your crew there. You had mentioned the commercial payer. Talk a little bit about that. What ACR members need to know about maybe any future trends or things that you're kind of anticipating just in the next year or so. What types of things that they can expect?
Yeah, so there's two hot topics coming out of this. One is the No Surprises Act, which really is a commercial payer legislation that has transferred a significant amount of power to the commercial payers. Now, the original legislative intent, most of the House of Medicine was behind, including the college. But as always, the devil's in the details. And the subsequent regulation was quite harmful to the provider community, not just radiologists, but all clinicians and
Right.
hospitals. That's been subsequently revised after some legal challenges, but we're still in a legal limbo here. It's given a significant amount of power to the commercial payers. We're already starting to hear abuses of the IDR process, this process where you have an independent dispute resolution, where you're challenging what you've been paid by the commercial payer. We're hearing of either pushing the boundaries of how the RDR can be interpreted to frank abuse. The ACR is going to be creating a forum where we can start collecting these abuses because if, and we probably will need to go the congressional route, we are armed with information of what's happening around the country. So you're going to see this come out of the ACR soon, where we're going to have the ability to report any abuses inside the No Surprises Act. So if we need a congressional fix, we can do that. The other big topic facing radiologists in the commercial world is this concept that the commercial payers are launching. They cloak it in a value-based program, which really is a code for limited networks, or we're only going to pick and send patients to imaging centers that are low cost. They try to cloak it in, well, we're looking at the type of equipment and the value and the infrastructure of the imaging center. But what it comes down to is how many multiples of Medicare do you charge, and is a commercial payer willing to pay that for your services? And we've met with the commercial payers a couple times because you cannot put an imaging center that has a half a Tesla magnet. And for those who are not familiar with that, that's a fairly weak magnet that maybe should be used in very limited clinical situations. You shouldn't be paying that the same as you pay a very advanced piece of equipment, such as a 3 Tesla MRI magnet. Yet the commercial payers are not necessarily allowing for that kind of quality differential. And we've made that points to them. They understand them. We keep pushing back on making sure that the limited networks aren't so limited that they're excluding really high value practices, including academic medical centers. So those are the two big pushes on the commercial payer world.
So then, I don't want to say the main reason we wanted you as our special guest for this episode, but certainly a large reason was because we just had the proposed rule come out for the Medicare Physician Fee Schedule. And so with that having just been released, what takeaways do you see from that?
Yeah, so in all honesty, it's a summary of some of the points I've made, that our teams under the Economics Commission have done a terrific job, but budget neutrality and other mechanisms of reducing our payment outside of our control, but inherent in how physicians are paid across the country, have been rearing its ugly head. So in the fee schedule, if you look at radiology specific services, there's really not a lot of action. There's a lot of maintenance of RVUs. We did a pretty good job. Where you see the cuts to our reimbursement, and there are cuts to our reimbursement, is once again, we had valuation of services outside of our control, namely the evaluation and management inpatient consultative codes. It's when a doctor gets called for a consult on a bedside, let's say a neurologist gets called for a headache consult on an inpatient. Well, they bill a service there. Also, the emergency room sees patients, they bill services there. Those code sets have gone up. They're billed tens of millions of times a year. In order to pay for their increased value, you have to reduce what we call a conversion factor. That conversion factor is multiplied by our RVUs, giving us less payments per RVU than we did before. And once again, that's what's happened. So several years in a row, we've had cuts, not because of our fee schedule, but because the conversion factor was reduced because of payments needed for other services inside the physician fee schedule. And we see that all over the rule this year. And there's some other nuanced things. Again, this is a proposed rule, meaning that it's subject to change, and it's subject to change based on stakeholder input. And we are obviously a stakeholder here, and we'll make comments. There are also some changes to the professional liability insurance. We feel the calculations are misguided at best. They lead to reductions in payments to radiologists, and we are absolutely going to argue those. We think that there's some errors in the assumptions, and we don't know if they'll hold. And maybe those cuts will be, some of the cuts could be reversed by the time the final rule comes out, probably at the end of October or November.
So you have the comment period and you have the final rule. And it's interesting. It's always, every year it happens. It's like talking with our economic staff. It's like, well, are they going to enjoy 4th of July recess or not? Are you going to enjoy Halloween or not? Because it always seems to be right around those areas. And I know that, at least with the final rule, there's been plenty of jokes about, oh, it's appropriate that's around Halloween because it's pretty scary stuff that they announce. So real quick before we get ready to close, I want to be super respectful of your time. Obviously, you've got a lot going on with your clinical responsibilities and then all the volunteer leadership you're doing on behalf of the college, which we're so appreciative of. What if someone's interested in this, they want to learn more about it, they just want to maybe have some questions answered, where would you direct them? Is it just contact the ACR economics department, or is there a way for them to get more information? I know we have our Advocacy in Action e-newsletter that gets sent out every weekend. I think it's like on a Saturday it goes out. What would you recommend for folks who just want to get more involved or become more familiar with what's happening?
Yeah, and so there's obviously different levels of involvement. If you want to get as involved as I have, I strongly suggest developing skill sets locally in your practice and then doing something bigger. For example, on the state level, bringing those skills to your state chapter or reaching out to the Economics Commission. We have a number of committees that deal with commercial payers. We have committees that deal with subspecialty interests like economic issues for neuroradiologists or women's imaging. We have committees that deal with Medicaid. If something Medicaid on your state level or in your practice is an important entity and you want to learn more about it and you do at your practice level and want to get more involved, reach out to us. I write an ACR economics chair column every month for the ACR Bulletin. I don't always write it. In fact, many of our team members write it. They do a great job about their specific specialty interests. That's a resource. Many of our team publishes research articles in the JACR or other journals. There's a lot of avenues to educate yourself, but always reach out to us, the Economics Commission. My email has been available through the ACR very easily. I set up phone calls with members all the time to talk about what's going on in the local practice environment. So don't be afraid to reach out to me. I'm happy to discuss topics of interest to any of our members.
And you guys have a ton of information on the ACR website under the Advocacy and Economics tab. I just went to it.
Sure.
And I feel like you could spend a lot of time just in and of itself going to some of these radiology economic links and learning something. So to close this out, we usually end with a lightning round questions. And they're a little bit off topic when it comes to what we've been discussing. It has nothing to do with socioeconomic. Well, I guess it could have something to do with your personal socioeconomic issues, but not college issues. What is your favorite food?
Yeah, this is my favorite food is something I don't want it to be my favorite food, but I can't help it. And that's ice cream. I have to have it all the time, sadly.
Okay.
But I love it too much. I
Okay.
also have 5 daughters who are young and are always asking for ice cream, so that makes it exacerbates that problem.
Well, you're just trying to
So
be a good, trying to be a good father.
good
That's all.
father. That's how I rationalize it.
I will say that answer seems like a very common answer, but we haven't had it yet, surprisingly. But when Dr. Bello said hers was hamburger, I almost fell off the chair. I couldn't believe that. Of all foods, it was a hamburger.
Yeah.
Favorite place to travel?
Yeah, so this has to do with family. I'm actually my dad's Egyptian by descent. Most people wouldn't know that from my name or how I look, but my mom is an American. So I love going to Egypt. I have family there. I find it to be an amazing country with warm, friendly, really outrageously fun people. So as much as possible, I like to visit Egypt.
Very cool. Not including what you do on behalf of the college when it comes to the socioeconomic issues. What would be a favorite hobby or activity?
Yeah, so this is a recent one. I got remarried recently. My wife is actually in the Economics Commission as well. Lauren Nicola used to be Lauren Golding. She got me into tennis over the last year,
Okay.
and it's extremely frustrating. But man, do I love it and try to play it as much as I possibly can.
But you're not doing the pickleball thing. You're doing like
No,
legit
not
tennis.
pickleball. I'm
Okay.
doing tennis. I haven't picked up pickleball at all.
And then although the pickleball thing is pretty popular, but
It took all my tennis courts are gone because of pickleball. So you're bringing up a sore point repeatedly.
and then last but not least, favorite saying or quote, whether it's just something you go by yourself or one that's well known and famous, any particular quote that you like to fall back on?
I'm not sure this is well known, but it's something I live my life by, and I think it's a testament to nowadays society. And it was said probably by many people, but I remember hearing it when I was a kid in the late 70s and 80s by James Burke. If you remember who James Burke was, he was a science historian from the BBC and did a show called Connections. And he once said, "The truth is what you believe, and if you are wrong, you have no one else to blame but yourself." And there are so many truths out there nowadays and a lot of blame going around, but the blame should be back on yourself if you're wrong. So I appreciate the grayness of that quote quite a bit.
Hey, look, I really appreciate your time. You and I have not had the opportunity to interact too much. Our paths have crossed a little bit because of the advocacy, but because I'm more in the actual government relations space and you're a little bit more in the economics, we haven't had that much opportunity to interact. But I really enjoyed the time together. I mean, very valuable information that you shared with the folks today who are going to be listening. And then really good insight on you as a person with the lightning round questions. So that was fun to see as well. So I want to thank you for your time and thank you for all that you do for the college. I can't say that enough because it takes a lot. It's a labor of love, I would assume, right?
Yeah, absolutely, Ted. And I obviously the thanks return right back at you and all your staff. I know exactly what you do all the time and follow it because it either has impact on us or is affected from us. And I really appreciate all the work you do as well. So thank you.
Well, I appreciate that. Thank you. Enjoy the rest of your summer, and hopefully Halloween won't be too scary as a result of the final rule. But we'll keep our fingers crossed.
Great. Yeah. Thank you. Take care.
All right. Take care.